both an honor and privilege to introduce our esteemed speaker for today's program, Dr. Bipin Jethani, a highly accomplished and dedicated academic in the field of homeopathy. Dr. Bipin Jethani serves as the head of office and professor, Department of Organon of Medicine, Nehru Homoeopathic Medical College and Hospital, Government of National Capital Territory of Delhi, bringing with him over 22 years of teaching experience in this role. Sir has completed his UG degree from Nehru Homoeopathic Medical College and Hospital, New Delhi, and holds an MD in Organon of Medicine from Sri Sainath Postgraduate Institute of Homeopathy, Allahabad. With a passion for curriculum development, Sir is Chief Coordinator of Committee for finalizing CBDC curriculum for MD Homeopathy in the subject of Homeopathic Philosophy. He is a member of the PG Academic Committee constituted by Delhi University and appointed by UPSC as moderator for subject of Organon of Medicine for recruitment tests for medical officer. Sir's contribution in shaping the future of homeopathy is remarkable. With his excellence in clinical practice, Sir also serves as master trainer for National Homeopathic Medical Council Hospital, conducted video conferences to sensitize undergraduate and postgraduate students to COVID-19 preparedness, response and containment measure in April 2020. He has undertaken many researches on various topics and also regularly organizing CMS, seminars and workshops on research methodologies for updating the professional and research skill. For the innumerous dedication in the field of homeopathy, Sir has been awarded with various awards, including Recipient of Hahnemann Award in 2008, Dr. D.P. Rastogi Award in 2013, and Special Appreciation Award 2018, and many more. Sir has presented various scientific papers in both national and international conferences and also published many articles in various publications. With his multifaceted expertise spanning teaching, clinical practice, research and community work, Dr. Bipin Jethani is an exemplary leader and an inspiration in the field of homeopathy. Please join me in extending a warm welcome to Dr. Bipin Jethani, whose dedication, expertise and contributions continue to elevate the field of homeopathic medicine. I kindly request Dr. Skandan S. Kumar, welcome Dr. Bipin Jethani with a floral bouquet.
Thank you. So, good afternoon. After a heavy session in the morning, I suppose we are back to our usual self, or is still heavy attendance going on? Anyway, so thank you. And see, basically, before I start my presentation, because all of your colleagues, we are teaching a subject for so many years. Many of you are senior to me, some of you are the same age. So my idea of presentation is not to in any way give you any teaching of Organon. What I want to do is, how have we framed the curriculum? What is the basic structure? What is the flow of structure we have tried to maintain in first year and second year? How in different semesters we can increase the competencies to achieve EPA? What are the important learning methods which we can adopt? And what are the different assessment methods? And for each assessment method, I'll try to give you, I'll have prepared certain sample questions so that we know what we have to ask and how do we assess. Right? Because ultimately, what is more important is to give a structure to our teaching. So keeping that in mind, I have prepared my presentation. Obviously, you all of us know that the actual sheet has been circulated to all colleges. So contents we all know. It is just a guideline that I need to give you as how it can be implemented. First of all, what I was discussing, before I go on to that, let me tell you one more thing. These guidelines which you have are just blueprint. You don't have to follow them, these guidelines word to word. Why I'm saying so? For example, I have to teach a very simple topic like as simple as, let's say, biphasic action of medicine. Right? So everyone, एक बच्चा जो first, so I suppose I should not talk in Hindi, I should talk in English. So any student has learned primary action and secondary action of medicine in PHMS. So we are not teaching him primary action or secondary action because that knowledge he already has. What we are supposed to teach in MD is how do we correlate that primary action and secondary action with modern pharmacology. How can we use that knowledge in clinical bedside? How would it help us in human pathogenetic trials? And when you see a case prognosis, how does the biopathic action of modern philosophers and modern homeopaths give us some insight into prescription? So the idea is that we already have the first three levels up till the competency PhD student already knows. We have to work over and above that. And for example, there's another topic like correlation of philosophy, homeopathic philosophy with modern philosophers. So I have taken Hegel, I have taken Immanuel Kant, I have taken Leibniz, Stahl, Karl Popper. That doesn't mean that everything you have to teach, or that doesn't mean that you have to read Karl Popper from starting to the end. All we are trying to say is, let us teach a student of PG Organon how to correlate. Let us give him the vision. He needs to understand modern philosophies and its correlation with animal philosophy. Right? So it's just a blueprint. You can add to this blueprint. It is not that this is set guideline. You can always add to what is there already, but it is just to give us an insight as to what do we need to sensitize our students. Right? So the first thing is these, whatever has been shared with you in the curriculum, are just directives or the guidelines to empower the student. Because that's the second step. The idea of MD should be to transform. Morning we were talking there are two ways of teaching. One is transmissible, another is transformative. So we have to open the perspective of the student to transform his competencies and lead him to EP. So the important part of the planning when we were doing the planning for this curriculum, our idea was to do the transformative process. Right? The third important point which we were addressing in this curriculum was emphasis on EPs. At the end of the day, what would differentiate a BHMS student from the MD student is ability to perform the task without supervision and ability to deliver it to the students. For every topic that we've taken in our curriculum, our emphasis has been that PhD student should utilize his competencies in the given subject. For example, posology, for example, susceptibility, for example, case taking, for example, prognosis, for example, history of medicine, for example, history of philosophy. So all these examples, what we tried is, we have already the knowledge, we already have the certain domains of skills. We have to improve or upgrade those skills to the level of EPAs and ensure that each student is able to perform the task on his own, and thereafter monitor those who is propagating the task in every clinical situation possible. Right? So the third important concept that we kept in mind while developing the curriculum was that we should be able to develop competencies into EPA. And the fourth important point was to give it a clinical orientation. Right? The subject matter doesn't change. What changes is the clinical perspective. So throughout the curriculum, we have tried to incorporate clinical skills with the topic which we have chosen, so that the fundamentals of homeopathy are integrated with the fundamentals of clinical medicine. Right? So this was the basic philosophy we kept in mind when this curriculum was being framed. I hope I'm clear to what was the basic concept that we took when we started working on this curriculum. To give it a smoothness of flow, see, my own experience with MD teaching was, so far we were teaching MD topics in a vertical manner. Vertical manner, what I mean to say is, let's say if a student is being taught from a particular philosophy, for example, Stuart Close, or a student is being taught from Dunham, and then the same topic the student is reading from another book in second year. like lesser writings. He may be reading from lesser writings, or he may be reading from journals. Idea should be the same topic should be covered in at all levels in that particular year of study only. I'll repeat that. How we have divided the course topics. When we were planning MD1 and MD Part 2, we thought, let us have a structure and what are we expecting the student of MD1 to know and practice, what are we expecting the student of MD2 to know and practice. Right? MD1, our emphasis was that the student should understand the evolution of philosophies, as to where did Hahnemann get the thoughts, the philosophy, what were the philosophers who influenced Hahnemann, what were the philosophers who influenced post-Hahnemannian thinking, and what was the role of history of medicine, how the thought of the philosophy has evolved. Similarly, another emphasis was basic concepts have to be critically analyzed. Third, research methodology, and fourth, clinical symptomatology with the fundamental. So we have kept all these topics in first MD1. For MD2, we have tried to give it more a clinical shape. The homeopathic principles in terms of disease conditions, homeopathic planning in terms of preventive, therapeutic, curative, rehabilitative in different clinical settings. Then different levels of management of the patient, be it like from a simple acute, like how to deal with an indisposition, acute disease, then chronic disease, so on and so forth. What are the different levels of management and how can we correlate clinical medicine with homeopathy in different levels of management? Then what are the modern philosophies we have which corroborate with homeopathic philosophy? What are the different schools of philosophy, homeopathic philosophy, which are prevalent? See, as a student, we all know that there are multiple schools. You have a Jan Schwanten school, you have a Sankaran school, you have a Frederick school, you have a Segal school. So what we have to do is we have to give them, our students, an orientation. It is his choice, it is his wisdom as to what he adopts or doesn't adopt. But we just have to open his perspective that other than what is written in the books, there are different journals and different literature which talks of different schools of philosophy. And obviously we have to give him some guidance as to how to write down a good medical scientific paper. So this was the structure of part 2. So part 1 was more to do with the evolution of concepts, basic critical insight into the concepts, and the research methodology and clinical medicine integration. Part 2 was more to do with the management of diseases in different clinical settings, the fundamentals in different clinical settings, then modern philosophy and different schools of homeopathic philosophy, and then how to write a good scientific paper. So these were the two broad headings under which we divided the syllabus of part 1 and part 2. And in all these topics we adopted an horizontal integration. Horizontal integration means whatever topic we are studying in first year, it has to be complete right from history of medicine to the modern medicine. It is not that if you are talking of individualization or if you are talking of pathology, so you have to complete it in first year in all respects, from first step to the second step. It is not that we are studying the same topic in second year, which was one of the lacunas of the old syllabus. Right? This we all know. These are the components. Part 1 we have morning also we were discussing. So you have in part 1 you have paper on fundamentals of homeopathic philosophy. The second paper is the fundamentals of clinical medicine homeopathic philosophy, research methodology and biostatistics. And part 2 you have paper 1 and paper 2 of specialty subject. My concern would be the fundamentals, because morning we have already discussed research methodology and the fundamentals of clinical medicine. So we have already discussed that. My concern would be to help you understand the framework of fundamentals of homeopathic philosophy and homeopathic philosophy for paper 1 and paper 2. Now this entire curriculum template is divided into certain points. What are those points? You have a brief description of the specialty subject. You have EP EPAs for each topic. Right? I'll take up one more thing. Whatever we are mentioning out here, I'll just take 1 or 2 samples of everything. My idea is not to give you the entire template because that template is already with you. It's just to give you what is the sample of that each point and what is the implementable part. How do we bring it towards our objective of EPA? How do we ensure that our student becomes trustworthy of doing that skill? So what are you may have your own methodologies, you may have your own ways of ensuring this, the techniques may differ, but what is our ultimate objective is to ensure that we are able to make our student capable enough to perform a given task in each topic.
Right? Everyone mentions homeopathic philosophy, only 3 parts.
Sorry.
Included the organ of principle. Fundamentals of homeopathic philosophy, paper 1, homeopathic philosophy paper. It's including organ of principle.
This paper 1 is completely organon. Paper 2 is the different topics of clinical medicine in correlation with organon. For example, if you look at the template, we have framed a template. For example, we have taken the example of dyspnea, we have taken the example of GI bleed, we have taken the example of liver diseases, we have taken the example of pain. All these concepts, how can they be integrated with homeopathic philosophy? In terms of investigation, in terms of clinical findings, in terms of clinical examination, in terms of history taking. Then in terms of case taking, in terms of prognosis, in terms of pathology, in terms of susceptibility, in terms of mathematic evolution, in terms so and so forth. So this is clinical medicine with homeopathic philosophy. This is homeopathic philosophy with clinical medicine. The emphasis out here is clinical medicine is your blueprint in paper 2, in which homeopathic understanding has been incorporated. The first paper is homeopathic philosophy is your blueprint, in the clinical medicine has been incorporated.
We are taking the term homeopathic philosophy. So organ of medicine is included in it or excluded?
This is one of the topics that we discussed. Since in the template, in the specialty subject, we have already written Organon of medicine and homeopathic philosophy. So for the sake of unnecessary repetition, we have just kept it homeopathic philosophy. Even the core studies, when you look at when we were discussing the codes, different codes of the core studies, the emphasis is homeopathic philosophy. Why? Because already in the first page, we have mentioned Organon of medicine and homeopathic philosophy. It's just, we could have written Organon of medicine also, but we chose homeopathic philosophy as a core, and since it is already taken for granted that this is a specialty subject of Organon of medicine and homeopathic philosophy, so therefore HP is the usual rule. But obviously, it's just for the sake of avoiding repetitions, nothing more than that. Organon of medicine and homeopathic philosophy. It's just for the purpose of avoiding unnecessary repetition throughout the template, because if you would have gone through it, already 135 page template. So that would have made it unnecessary much more bulky without giving us any clinical information. So what are the topics that we need to cover? The description of the specialty subject, what are the EPAs and what are the competencies in MD part 1 and MD part 2, what are the topic objectives, what are the topic descriptions, what are the different learning methods, what are the different assessment methods, list of reference books. These are the broad headings in which the entire template has been compiled. Right? Now, one important aspect that we looked into when we were framing the syllabus of homeopathic philosophy, which was previously kind of overlooked, was that when we started MD teaching in the earlier syllabus, we started directly with homeopathic philosophy. Now, what we wanted to convey was that this homeopathic philosophy is a specialized form of general philosophy. Philosophy as a subject has been there since a very long time. What we have talked in the initial part of first year is, I'll give examples, that out of that general philosophy has evolved the special philosophy of homeopathy. So initial part would cover certain aspects of Socrates' Now, I'm not saying that you have to go and completely read Socrates. I'm not saying that you completely read Aristotle. I'm not saying you completely read Hippocrates. But there are certain relevant points of their writings which influence Hegelian thought, which should be conveyed to the student. So the first topic that we kept was basically the evolution of homoeopathic philosophy as an outgrowth of general philosophy. And that is one of the objectives also of homoeopathic philosophy. So homoeopathic philosophy is an extension and application of general philosophy in the furtherance of healthcare decisions. Then, just to give a summary view of evolution of Hegelian and post-scientist schools of philosophy, understanding the fundamental aspects of homoeopathic science and its philosophical theory. Primarily, first 3 points we are covering in MD part 1. First, fundamentals of logic and scientific methods and their alignment with Hegelian and post-scientific concepts. Fundamentals of the evaluation and management of disease at different levels of healthcare delivery system, and validating and advancing the understanding of homeopathic principles and engaging in evidence-based clinical practice is the second. These 3 topics are the MD part 2 primarily. Although there will be a lot of overlaps, but primarily focus was to cover the first 3 topics in part 1, and the MD2 was to cover the next 3 topics in the part 2 of the MD curriculum. Now, we have already talked in the morning what is EPA. I need not take this up, but one important thing that I should surely tell you is that for every competency which we will be discussing in homeopathic philosophy has steps, and the top layer of that step is the EPA. Let us take one example. Well, you tell us, आप कोई भी ऑर्गेनोन topic, let us take. We are all teachers. For example, susceptibility. Now, when a student is a PhD student and he has read Organon, he has read Stuart Close, right? So obviously he has read what is the definition of susceptibility. He has read what is susceptibility to health, disease and cure. He has already read what are the factors influencing susceptibility, right? So he has already read this. So this is all part of the first level of competency, that he has the knowledge of so and so, right? In this, when we are talking of susceptibility, now where does our role start? Our role should start with understanding of the substantialist philosophy of Hegel, and then try to correlate from their take on the role of susceptibility in health in terms of the organic view of life, the role of susceptibility in disease in view of the organic view of life, the role of susceptibility in cure in view of the organic view of life. So you are taking him one step ahead. Then, how does the susceptibility, how does the concept of susceptibility give you an idea of the biopathographical evolution of disease? How does the susceptibility give you an idea of the socio-cultural determinants of health and disease? These are all topics we are supposed to take in MD. Because he has already read what is susceptibility. He has already read what are the factors modifying susceptibility. He has already read what is the role of susceptibility pathology. These are the things which we have already. You can obviously revise it with them, but these competencies are not complete. You have to complete those competencies so that at the end of the day, what would be the EPA in such a case? For example, susceptibility, what can be the EPA? For example, when we are talking about the competency of susceptibility, what would be the end point? See, EPA is the end point of all competencies. Because, see, it's just one simple example, as Dr. Munisa, when he was talking in the morning, you are able to take a case, can be a competency, right? You are able to analyze the case, another level of competency. You are able to evaluate and plan therapeutic, preventive and rehabilitative management, another level of competency. But you are able to do it in a difficult, one-sided disease, is an EPA. You are able to do it in a gross advanced pathology, is an EPA. You are able to do it in a surgical sober surgical disease, is an EPA. You are able to do it in drug proving, is an EPA, because you have to extract symptoms from the proof. You are able to do it during the process of drug proving, is an EPA. So EPA is the context driven. In every context, Dr. Munisa was driving a car is a competency. Able to drive a car in all scenarios is a EPA. So majorly you will find your MD students have developed a competency to a certain level. The idea is to take them to the EPA level, and therefore EPA is the end point of competencies, and that is why then only you say entrustable. Then only now I trust you that you will be able to deal with this patient, whatever be the clinical condition. You would be able to refer him if you know when to refer. You will be able to guide him as and when it is required to be guided. You will be able to give him general management as and when he requires it. So you are competent enough to perform the task as a work. So always remember, competency is a descriptor of a physician. EPA is a descriptor of a work, of a task. Clear? Because these are the words we will be using throughout the structure of the curriculum. Am I being?
Since morning, there is an entrustable thing. Everyone saying trustworthy, trustworthy. Is there any other meaning for that? That is dictionary meaning. Entrustable, trustworthy. Is it that?
Entrustable and trustworthy. Trustworthiness is one aspect of EPA.
For entrustable, you are entrustable.
Entrustable means I have not now made you trust. I have given you the trust that you would be able to do this on your own and guide others.
Other than trustworthy, is there any other meaning for entrustable?
Not to them, not to others.
Because it's not entrustable.
Entrustable is, see, let us not go too much into linguistics. Idea is a very simple thing. The idea is from BHMS to MD level, we should be able to ensure that in any context, physical, clinical context, the PG student should be able to handle without supervision and propagate this information to his juniors. That's the most basic concept. That's the most simplest and the basic concept for which we have put each topic. Right? Competency, we have already, competence requires three things: knowledge, skill. So knowledge is what you read, right? Skill is what you do, psychomotor, and the attitude of behavior is how you, what is the communicative and the cognitive. So if I have to put this, knowledge is head, skill is hand, and the attitude is heart. The 3H. The 3H. Head, what is going through your books or different sources, what is the knowledge you are gaining, how you are doing it is the skill, and when you are reflecting upon it from the emotional point of view, communicative point of view, ethical point of view, is all part of attitude. So the competence would involve for every. Now why am I giving you the basic? Because every topic has been divided into these concepts. Every topic that you would see in the template has a topic of knowledge, has a topic of skill, has a topic of reflection. Right? And so this is a kind of a integration of these topics which gives you competence. Now those who have, this is a spelling mistake, this is Miller's actually. We all have read CBDC undergraduate curriculum, right? One important aspect was the Miller's pyramid. I hope we are through with that. So the end point of Miller's pyramid would be covered in PG. For example, this is what we were talking in the morning, right from a novice to an expert. Novice means I just know. I know that this car has a brake, this car has a steering, this car has a clutch. I know this. So I started as a novice. Then how to use clutch, how much to press, where, how to correlate with clutch, how to correlate with brake is knows how. Shows how when I start doing the assessment part, when I start doing the peer-based interactions with the students in the clinical setting, in the bedside, is shows how, and does is EPA. Now I can do it. I know it, I can show it to you, I know how it is to be done, and now I am capable of doing it. So the Miller pyramid end point is the EPA. Right? I will be talking about OSCE. OSCE is one of the important components which we have introduced in MD assessment. I'll tell you how OSCE can be when you're taking a clinical examination of a student or a viva, how can you use OSCE as a tool of assessment? So, but that's later part. Now, what are the EPAs that we have framed in our subject? You already have the template, so I'll just take one example. What are the EPAs? How have we mapped those EPAs? I'll take one example. And how are we progressing in EPA semester wise? Is another example. Okay? So, what we have done in the curriculum, what are the EPAs for a homeopathic physician from homeopathic philosophy point of view? What are the mapping of each EPA? Domain mapping. We were discussing there are 6 domains: knowledge, patient care, homeopathic orientation, communication, professionalism, practice-based learning. These are 6 domains in which each EPA has been mapped. Okay? And then, starting from first phase as a novice to an expert, in each semester what he has to do to achieve that EPA for each topic. Am I clear? Yeah. No, I tell you what. For example, you have a good question. I'll tell you everything. For example, we are talking about the understanding of the fundamental principles of physics science. And in the next topic, we are talking about fundamental logic and scientific methods. Now, these 2 topics apparently would seem to be they are 2 different concepts, but they are actually an overflowing of the concepts. What I meant was what I meant by horizontal integration was, if you have completed a topic, not the EPA, if you have completed the topic, is that topic or a competency, that competency should be completed at that point. Now to go to the EPA, you need another competency. So for example, you are driving a car, the first competency is that I know about the clutch and the working of the clutch. The next competency is that I am able to maneuver it through a narrow road. Right? So the competency 1 and competency 2 in part 1 and part 2 have to be completed in a horizontal manner. Both them, when will be combined, would give me the EPA. Right? So that's why I am emphasizing the 2 different concepts, competency and EPA. For competency, we are doing a horizontal integration. For competency, EPA would come only when all the competencies have been horizontally integrated. That is what I have written when we discuss this. See, if you go through this, EPAs are not alternative for competencies, but a means to translate competencies into clinical practice. Competencies are descriptors of physicians, EPAs are descriptors of work. EPAs usually require multiple competencies in an integrated holistic manner. Am I clear on this again? For each competency, you are doing a horizontal integration in that particular year. The integration of multiple competencies gives you the EPA at the end of second year. Am I clear? Yes. Now, for example, these are just one. Now, whatever I am detailing, all of them it is in your curriculum template. I am just picking up one example as to what can be the different EPAs. Right? So, aligning different schools of philosophy, clinical decision making in homeopathic patient care, evolving the biopathography of disease as per modern and homeopathic concepts, so when I say that I am able to analyze the socio-economic, environmental, biological and emotional determinants of health and EQ pathogens of disease as per modern and homeopathic concept, means now at the end of the second year, as an EPA this would be completed. But the competencies for this topic, EPA, would start right from first year, go on till the final year, right? So each EPA has competencies, each competency has knowledge, skill and reflection chapter. For each competency, when it is completed in any horizontal manner, you move on to the next competency. All competencies together give you the EPA. And this is done for all the 32 hot topics that we have. The topics are absolutely the same what you're reading in. There's nothing, we have not added anything from outside to give it empty homeopathic philosophy. See, that is said, when I started, I said that idea was to give you transformed perspective. As a PG student, you have to open up his mind to the same concept which is reading in the PHMS level, or which is already read in the PHMS, right? So it's a transformative process, not a transmissible process. Obviously, transmission is part and parcel of it. But idea is to help him empower that he can critically analyze things on his own. That is why we use the word PG guide. We are PG guides. We are guiding the student to do a self-directed learning to understand the concepts. Right? Similarly, the other EPAs are performed holistic homeopathic case analysis plan. These are randomly I've taken. We have all the EPAs in the list. Just to show you what plant pathology, light of homeopathic philosophy, special evidence and evolving perfectibility, interpret the knowledge of modern philosophy and concept and further the holistic ingredients can talent, concern and health, disease and life, health and disease. Evaluate the modern schools of homeopathic philosophy and their relevance in medicine and understanding formation. So these are the different EPAs. Mapping, we already discussed in the morning. I'll just take one or two EPA to understand how the mapping is done. So mapping is basically, so this you can do it on your own. See, there is, when you understand what is, see, knowledge and scholarship is what you read from books or any literary source material. Patient care is when you're doing it at the patient's bedside. Homeopathic orientation is when it is applicable to homeopathic philosophy. Communication skills is where you are interacting with the patient, your communication skills. Practice-based learning where it would require a skillful application in a patient bedside. And professionalism is your ethical part. Right? So now, with this background, you can yourself make, for example, when we're talking of related homeopathic philosophy and extension general philosophy. So right now, we're not dealing with any ethics, we're not dealing with patient care, we're not doing any communication. What we're just telling you is homeopathic orientation. We're just telling you the knowledge and we're just giving you the patient care, how would it help in patient care. Similarly, when you analyze when you start reading about the accessory circumstances, in a given case you start analyzing the accessory circumstances of it. Now how can you dealing with the patient? You're dealing with there is a degree of communication that you need to have with the patient. So therefore, this would cover 5 domains of competence. Right? Similarly, now when you're talking of the psychological part of it, when you're talking of the interpersonal relationship with the patient, then professionalism will also come in. Right? So once you understand the concept, you yourself will be able to map the EPAs. There's nothing, once you understand the concept and the EPA, the mapping would come automatically on. Right? Now what are the milestones of achieving EPA? This is the level we start from first year to the final year. Right? So the first would be learner is able to do with the help of active help of teacher. He needs you to teach. Second level, in the first level, learner is not enacting. Second, the learner is enacting with the help of a teacher. Third level, learner is able to carry out as and when required help of the teacher. Right? Fourth is, now he is able to do it on his own. And fifth is, he is able to give it to the others. For every topic, we have 5 levels of EPA. Right? So the first level is, I am giving you knowledge. Right? I am just telling you this and this. Second level is, I am orienting you to knowledge, but I am also doing an enactment for you as a co-learner. Third level, this is what we discussed in the morning. So third level would be, this topic I know you can do, but if you require my help, I will be there as and when required. Fourth, now completely left you on your own. And fifth, as and when you have learned it on your own, you have to give it to the teaching part, give it to your juniors. So this is no permission to add to this. These are the same levels. In your template this is written, but I have taken up this to explain you why this has been written. So for example, if you have to take one, now this again is suggested, means this is just a guideline. If you want to finish the same EPA in first semester, in the first itself, you can do it, not an issue. It is not that we are stereotyping it कि आपको first EPA का first level semester 1 तक ही रखना है, semester 2 तक नहीं चलेंगे. Absolutely not. You can cover the all levels in the first semester itself. Am I clear on this? That is the thing. This is just a guideline. It is not required. We have divided the guidelines according to the level of learning. So, for example, if you understand, for example, philosophy, so first I need to know what is general philosophy. Then I need to know what are the different schools of general philosophy. Then I need to know what is the philosophy of empiricism and rationalism. Then I need to know rationalism in terms of modern medicine. Then I need to know understand the empiricist philosophy specifically of Bacon, Hume and Locke. And then see to it how empiricism and homeopathy are correlated. Now these are different levels. Doesn't mean that you cannot finish it in the first semester. These are just the levels which you have to achieve at the end of that particular term. Now this can be done in 2 semesters, it can be done in 3 semesters, this can be done in the, if you want, go on to 6th semester. Right? So this is another example. For example, you have to teach the student how to publish a scientific writing. So what you have to first tell him how to analyze the published literature. Second, demonstrate the importance of literature in terms of homeopathic philosophy. Then validate the homeopathic principles in light of modern researchers. Then identify what can be the avenues of scientific validation of homeopathic principles. Then submit a feedback which can be further adopted and then demonstrated to the class. Right? So what these are is, what are the different levels in which we can achieve the competition. Right? Now these are the, keeping this in mind, because this was the basic framework of part 1 and part 2. These are the topics of part 1. So the emphasis was the history of medicine, the influence of different schools of philosophies in the evolution of, this is all there in your template. So up till this point was the basics of our coverage of first MD, MD1, and this is the coverage of MD2. This one, general pathology of homeopathy in context of animals and description. Right? These are general topics. Then when you come to the paper 2, sorry, one more important thing which should be very clear to all of you is the coding of the topics has been done in continuity. So what you're teaching first MD part 1, when you go to MD part 2, the topics would continue in the same coded. So after 14, which we covered in MD part 1, the next 35, up to 35 would be covered in MD part 2. Right? These are fundamentals of clinical medicine. Now, the next, after topics, you will find in your template topic content. Now, what is topic content is, what are the points you have to cover in that topic? So again, I did one example. For example, if you have to read different influence of different philosophies in the evolution of the principle, so then you read, because see, when I'm saying you read the philosophy, I'll just give you the gist of it. Now we're going into detailing. So the general philosophy of contemporaries like Aristotle, Socrates, Plato in the influence on evolution of homeopathic philosophy. You review the writings of Hippocrates, Immanuel Kant, Paracelsus and their influence on homeopathic philosophy. The influence of the philosophy of Gide and Francis Bacon and on Hahnemannian philosophy. Then the Swedenborg philosophy on Kant, history of modern medicine and the influence of development of homeopathic philosophy. So these are the content of the topic. Right? just give one example, just to help you understand as to how we have to approach the topic. Right? So for anything which is not very clear, see, let me tell you very frankly, when we started with this project, the EPAs, competencies, it was very new to us. It was absolutely very new to us because number one, we were not trained in the pedagogical approaches. This concept only we started doing and reading the literature and when we started doing the brainstorming, then we understood that how do you do the levels, how do you structure the levels. So it's not, so this is kind of an attempt we have put to correlate learning methods, educational techniques with homeopathic philosophy. What Dr. Munir taught in the morning, we have incorporated that with homeopathic philosophy. First, to give it a structured, competency-based curriculum. Right? But one thing we have done to simplify the matters for all of you. For every topic, we have given you reference book, which other subjects have not done. So what we thought was, instead of writing the list of books towards the end of the entire template, for every topic we have given, where do you refer to?
For every paper they mention.
For every topic.
For every paper they mention. Paper 1, paper 2, paper 3.
But they have mentioned paper, but we have done topic wise. Because until see, if I don't know where to look for this, then where do I search? Because in the end there is this list of all the books. But where do I read this? Where do I read this? And again, that is not exhaustive. That is not exhaustive. Again, that's whatever to our understanding you can use for comprehending this topic has been mentioned in that description. Right? So, just to give you one example. Now, talking of this, if you have to read there's a book by Anthony Campbell, Two Faces of Homeopathy. There's a book by Anthony Campbell, Two Faces of Homeopathy. If you read that particular book, a lot of things you would find in that book itself. Right? So I'm not saying that you have to read Gita separately or you need to read Swedenborg separately. You will find it in those books. So just to simplify the matter for all of us, we have written the books along with the topic. Right?
Sir, I have the morning in the morning session we were told that you should not have any classroom teaching.
You should not have any.
Classroom teaching for PG.
Sorry,
Classroom teaching.
It's only for paper 1.
Let me put it. I'll put it in the right perspective. See, that I'm saying, competency doesn't come with knowledge. Knowledge is the starting point. Emphasis is on clinical teaching. See, first, when you read the structure of Organon, first 5 topics you find most of them theoretical. But 6 onwards we made it clinical in phases. So 10% is 10% classroom and 90% is, we're not putting a cap on this. What we're saying is we need to move from knowledge to skill. Other topic, A, knowledge based. I'll tell you when, to clarify your point, let me come to this point. Now, if you, when you go through this particular topic, right, this is the topic description. जब आप पढ़ेंगे इसको, when you read this last line is, last component is domain of competency. Domain of competency writes whether this topic is knowledge based, or whether this topic is skill based, or whether this topic is reflection based. So for example, this is skill based topic. Just an example. So first 5 topics are actually knowledge based in your curriculum. Nothing to do with patient care. So we are not typifying that MD is all about clinical, nothing about the classroom. What we are saying?
Fundamentals of clinical medicine, relation homeopathic philosophy. The whole paper is.
That's all come clinical. So, but even the fundamentals of homeopathic philosophy, other than the first 5 topics, you will find you moving to clinical. From the topic onwards, you're gradually moving towards clinical, right? So this is an example of topic content. Topic content is elaboration of that topic as to how you will achieve, what are the points you need to read in the topic. Right? Topic is a general overview. Topic content is the details of achieving that topic. Right? So for example, if you read the schools of modern philosophy, then what is the relationship of philosophy, science and metaphysics, examination of the Immanuel Kant concept, interpretation of Jungian concept of archetypes and synchronicity, organic view of holistic science on the base of Hegel, doctrine of energy on the base of Nehru. See, I again emphasize one thing, is not that you have to, this is not a prescriptive syllabus. This is not a prescriptive syllabus. You feel you do not want to teach Hegel, go ahead, need not teach Hegel. We have just given you an idea. We have just given you an idea, and neither is this all exhaustive. Neither is this all exhaustive. We just have given you an idea that you can explore different philosophy to make the child understand, the student understand how is modern philosophy correlated with homeopathy. You can add on your own, or you can may not give emphasis on all of them. Right? So that is why when I started with the presentation, our curriculum is basically guideline or a directive. We are requesting the teachers to follow this direction. For example, if we have in the last topic of this Organon is the overview of different emerging schools of homeopathic philosophy. So in that you can take up anything. If you think your child, the student should know about, for example, the Ortega method, orient the child. You think after all came too much into spirituality because of Swedenborg. So your student would be as you're thinking as a teacher. If I am influenced, for example, by predictive school, I may want my child to know about predictive school. But what we are saying is, don't give him just the predictive school. You teach him about the Segal school also. You teach him about the Professor Sanchez school also. You tell him about the Jan Shorten school also. You tell him about the synergy concept of Rajan Sankran also. And let him decide. And you can add to this. I am just giving examples as far as I know. You can always add to this. So this is not a prescriptive syllabus. This is just a direction not to miss on this topic. Am I clear to everyone? Then what are the topic descriptions? Topic description are for every topic. So we have a topic content, then we have the topic description. Topic description gives you what is the overview of the topic, what this topic wants to tell you. Each topic, all 35 topics. For every 35 topic, there is a table of topic description. What is the overview of the topic? What are the competencies you need to achieve in terms of knowledge, skill and reflection for each competency? What is the learning methods you need to adopt for the child to understand that topic, that competency? How would you assess? What are the prescribed books or text to understand that topic? And what is the domain of competency? Whether it is knowledge based, whether it is patient care, whether it is communication, whether it is professionalism, so on and so forth. Right? So that's it. So when you open up your template, every topic has been tabulated in this manner. Right? So I am just taking one example. This is perhaps topic number 19, if I am not mistaken. This is topic number 19. So what we need to, when we are talking of integration of clinical, preclinical, clinical and paraclinical subjects into homeopathic understanding of disease. Right? So then these are the two competencies we need to develop in the child. Right? For these two competencies, what is the knowledge, skill and reflection? Similarly, second competency, what is the knowledge, skill and reflection? Right? Then what are the learning methods are taken separately? What are the learning methods you can adopt to teach the child, to train the child, to make him understand, to make him apply? How would you assess? What are the different domains of assessment? What are the different types of assessment? Whether it is skill based, whether it is knowledge based. See, knowledge based would have a different method of assessment. Skill based would have a different method of assessment. Reflection based would have a different method. Okay? Learning skill based would have different method of learning, knowledge based would have a different method of learning, reflection based would have a different method of learning. Right? So for each table we have given that. Okay? And then what are the learning method assessment prescribed, and that is said to help every teacher understand each topic. We have given the reference books in that topic itself, rather than writing at the end. Although we have written at the end also, but it makes more sense when you know what to refer to for that topic. Right? So far, any questions so far? For every topic, it can be just one competency also, it can be 3 competencies also, 5 also. Yeah. That is the view. Yeah, exactly.
So there are 22 EPAs that they have mentioned.
EPAs are, there's a difference between topic and EPA. After 3 topics, you can have one EPA.
But initially,
EPAs are, let me clarify. Topics, just 3 things. EPA is just the work. Topics are the knowledge, skill, reflection, which may not be mentioned in the EPA. For example, let me say, for example, I want a child to understand the concept of holism. Right? So my competency 1 can be what is holism, what is holistic concept. Number 2, what are the philosophies which vouch for holistic concept. Third, what is the concept of vitalism and holism. Fourth, how do you apply vitalism in the holistic care of patients. Fifth, what are the modern philosophies. Now, all these may be given one topic which may not be there in the EPA. Because EPA is just the task, your end product. Topics are not given are given to complete the EPA, but wording is not the same. At the end of these 30 points, I'll tell you one more example. In this template, if you want, one of the EPAs is to help him become part of interpersonal, become a part of a team and team management and how to lead the team. Now we don't have after topic, there is nothing like which complete this EPA because this is a soft skill. This child has to learn at the bedside. So there is no topic for this EPA. But this is an EPA. I get the point.
sir, I am asking they have mentioned
EPAs and topics are just a substrate to perform an EPA. There is no numerical correspondence with EPA or topic. Absolutely no numerical correspondence. I am giving you an example. There is one EPA for which there is no topic. If you read the last 2 EPAs, there is no topic. So there is no, EPAs are the quality of the work. Competencies and topics are the quality of learning of the teacher student. Learning and understanding. It is very much possible after 6 topics he may have one EPA. And it is very possible one EPA may not have any topic. Because he will learn side by side. When you go into the clinical bedside, obviously communication skills would come to him. Right? So, or he would understand how to work in a team. So for me that's a soft skill. That's a soft skill which I need to learn, which I need to do. But we have not added any topic for that. No checklist, madam. No checklist. This is not prescriptive. This is not prescriptive. What we want is, please complete those topics as far as possible in terms of knowledge, skills and attitude to the best of your abilities. Now everyone would have a different scenario. For example, I'll give one more example. For example, we have added one topic among the topics is the concept become logic. Let us take logic. Now, logic the child is reading from first year. Right? But he has been reading, when he was reading Stuart Rose, he was reading about Mill's logic. Now, we have to, so he would have read of Mill. But now, it's not that now my PG syllabus wants me to force Mill's logic into it. No, that is not required. That is not required. What is required is, when we have written Mill's, what we have said is the salient feature of Mill's, which the child could not understand in correlation with inductive logic or the formal logic, you give it to him. So that this would help him framing the totality of self. And that is why I have written Mill's logic in relation to totality of self. I am not saying that you need to teach him Mill. Yeah, I am not saying that you also start reading about Mill's logic in depth. So this is the syllabus never going to end. But the idea is that you at least convey to the child that Mill's logic is important when you are framing the totality of self. You are the what is the word? You are the coordinator. Say what is the word? Facilitator. You are the facilitator. But you could only facilitate when you know the topic. Right? So my first point of the presentation was that this is not a prescriptive. It is not another checkpoint that I have covered Mills, I have covered Hegel, I have covered Immanuel Kant, I have covered Karl Popper, I have covered this, I have covered that. No. These are ideas. These are concepts which we want you to put across to the PG students to stimulate thinking. Because we have to transform. We have not just to transmit. We have to transform to help him understand and empower, so that he can develop competencies into intrustable in an integrated way. Broadly speaking, this was the concept. Okay?
So when family classes, at the end of all this exercise, then we have to evaluate.
I'll come to that. Okay, so learning methods can be different. Now for every topic we have given what kind of learning method you can adopt. So if it's, for example, if I have found a topic is more of first of all, learning methods are two types. One we could do in a group and one I do individually. Right? So any topic which is which is individual based, you can do it in library based, e-learning, flipped learning, we have been doing a lot of flipped learning. Then space repetition, deliberate. Space repetition is when you keep on repeating the same thing. Deliberate practice is when you start incorporating into skill. So space repetition is for any knowledge based topic. Skill based topic is the deliberate practice. Right? Then formative self-assessment. Then peer-based review method is the problem-based, case-based, brainstorming, role-playing. So for every topic we have written, what are the learning outcomes you can use. Now it is up to you whatever you want to use. Right? Research methodology. Anyway, so. Let's see. At the perspective. See that thing. There is no cut-short solution anyone can give you about selection of topic. Now it is the critical thinking of the student, the literature available with the student, the understanding of problem statement, the ability to make a hypothesis, the ability to generate the variables, the ability to do a study design. Everything is kind of your own effort. Not necessarily. Not necessarily. If you're doing a quantitative research, quantitative research, not necessarily. It is what kind of, I want to do a descriptive research or I want to do an experimental research. If I'm doing a descriptive research, not necessarily. Then you have to take a clinical topic. But yes, for experimental research, I need to take a clinical topic. So idea of, see, what Dr. Prashad was telling you is that obviously you have to make the hypothesis. You have to understand the problem statement. You have to critically analyze the variables. You have to understand the outcome measures. You have to understand, but these are the headings in which you have to do it. The anti-curriculum is just giving the headings. It is not prescriptive. I am again repeating, No one can teach you Organon at this level. You are the master. We are just giving a direction. That this is the direction, which this is not a gazette. This is not a gazette that you need to follow the word if it is written. These are the directions which you should not miss in teaching, in clinical understanding and assessment. That is why, see, if I come to the assessment part, why have we placed this table? Is so that you have this table in mind that no topics get missed in your theoretical paper and you are able to cover each topic with the student. See why this table has been framed. This table has been framed, you cannot afford to miss the topic because then the student loses marks. So it's a kind of a net for us. They have put a net that neither afford to ignore nor afford to overemphasize. That's the basic concept. Now assessment. In the topic overview, in the topic description, first was overview, second was competencies, the knowledge, skill and reflection. The next was the learning methods. The next is the assessment. Now basically how do we assess a student? Normally, conventionally how do we assess? How do we assess? So far, in the current MD scenario, what is the assessment method?
Performance in the theory,
Performance in the theory. Viva. Dissertation. Casing will come into clinical practice. Micro teaching. Clinical examination. See, right now what we were assessing had three major limitations which we have tried to correct in this step. Number one, it was not structure. For example, I feel like my favorite topic is holism. So I can send the entire paper from holism. Or my favorite topic is Kent's 12 observation, which should not be, which is part of the second BHMS. But let's say I am fond of Kent's 12 observation. So I can send the entire 2 questions on Kent's 12 observation. What is the drawback? I am not giving the child the avenue to explore other topics. I am closing him down. So there was no assessment structure in theory or even in clinical or even Viva. Clinical means, for example, I say a child to start examining, this is a case of, for example, this is a case of GRD, or this is a case of peptic ulcer, or this is a case of erosive gastritis. Now you are starting now. Now it is my wish. I feel that this child is doing good, okay, he did a good case taking, I'll give 10 out of 10. Then another child who could not do good case taking but was good in telling you the case management. So I'll give him 2 out of 10 because my favorite topic is case taking. So this structure we have put even in clinicals. So for every step you have to give a mark. For every step which completes a clinical examination, this is what we did in asking. This is what we done in asking. So it is not my wish. It is not my wish I want to give him 10 marks. That is prejudice. I want to see whether he has done these steps in terms of professionalism. Has he developed a rapport with the patient? I'll give him marks. Has he greeted the patient and did interpersonal communication? I'll give him mark. Has he asked him his basic complaints? I'll give him mark. Has he gone into the biopathography of the patient, socio-cultural determinants? I'll give him mark. Has he talked about the importance of observation? I'll give him mark. So we have structured assessment. The first drawback of the previous years was there was no structuring finishing of the assessment. The second drawback was there were no tools for assessment. Everyone was saying you just take the examination, final marks and then you count. What about his formative assessment? A child who has been, you would be going through the same examples. Yeah, you have one very good student in the class, right? All through the years he was doing very well. But in final year, theory paper or first part on theory paper, he could not do well. So what is the reflection of the child? That is an average child. But in fact he was not an average child. So what we have done is incorporated formative assessment or internal assessment. And formative is also not my will. I like this child, so therefore I'll give him 20. Formative also have tools and structure. So that was the second change we did. First it was bringing about structure. Second thing was bring in the tools of formative and summative. And number 3 was the application of those tools. For every topic we have given you, if you read the topic description, for every topic we have given you tools you can choose according to your wish for formative assessment and summative assessment. Okay, except for the theory paper. Theory paper has to be standardized. Okay, I'll give you some example of theory paper, how to set, so that will be easy for you. So assessment, you all know theory and clinical. Theory is completely summative. Whatever marks you get in the final paper is a summative. But clinical and viva voce is both formative and summative. Summative methods, what are the different methods you can use? A problem-based question, a long answer question, a short answer question, viva or asking. Then for formative assessment, you can use, if it is a knowledge-based concept, you can use MCQs, assignments, group discussion, viva. If it is a scale-based concept, you can do a direct observation of procedural skills, TOPS. You can do OSCE, you can do the checklist, you can do the rating scale, and even mini CX. I will give you one example of mini CX. How you can do mini CX for a given topic. This is the basic. How do you do the formative assessment? Theory-based paper has to be exactly like this. So you have to give one problem-based statement for 20 marks, right? You have to ask 4 long questions and you have to give 8 short questions. Right? Now give you one example of problem-based question. What you have to do in problem? I mean, karna hai, what you have to do? Problem-based question would have basically components. First, you have to give us a case study to the student. Then you have to ask questions in some parts. You have to ask questions in some parts and assess the clinical skill of the examiner. Then it should evaluate the critical thinking and interdisciplinary approach, and it should cover different competencies of the given topic. I'll take one example. If you look at this, problem-based question has to necessarily come from one topic only, which is PG12. PG19 is also there, it's MD part 2. So I have taken one example from PG part 2. What can be this is 19th topic of MD. So for example, you can make a case that this was an 8-year-old child presented with recurrent episodes of breathlessness, especially after 2 to 3 years, in the last 3 years. The paroxysms were frequent in autumn season and after eating examination. The attack would be accompanied with cough and a feeling of tightness in chest. Typical shortness of breath improves with expectation of greenish mucus. So this was a case. You are giving a case to the student, but it has to come from chapter 19 only, topic 19 only. You cannot give any random topic in your problem-based learning. We have chosen that topic only, which is quite open-ended, right? The chest examination revealed no abnormality except that auscultation revealed moderate bleeding, which was also expiratory. Hemogram chest X-ray was normal. Spirometry showed low FEV versus the FEV this is the case study you do, right? So this is one example I've said to help you understand what is the kind of problem-based question we're supposed to give. Because we have to test the skill. Problem-based question will always be skill-based. So now, once you've given all the details for this topic, right? Now you can ask the question, what is this probable diagnosis and what is interpretation in context of the concept of idiosyncrasy? Explain the underlying pathophysiology of the disease and correlate with mathematical analysis of pathology. Describe the case management in light of the concept of non-febrile intermittent disease and plan the general management case on the basis of reward system. So you have given 5 questions, 5 marks each for this problem-based study. So your first question in every paper has to be problem-based study, right? So am I clear on this? How you can make n number of cases, but the important thing is whatever case you are giving, every case, every sub-part of that question should cover the integration of clinical medicine and homeopathy and the topic of which you are giving the, because it's skill based, na? So you cannot be asking what is the clinical diagnosis. Clinical is completely clinical medicine. You have to correlate it, what is the child's understanding, what is the student understanding with homeopathic philosophy of that clinical diagnosis. Similarly, how can you structure the LAQ? Now, why I put is, please, this is important, and this is a mistake I have noted in most of the teachers that we give. We straight away give the topic as the question. If the topic is general pathology of homeopathy, we straight away give what is the general pathology of homeopathy to the student. Now, this is not required. How can we expect him to write the whole general pathology in context of math? You have to be specific in what, that is the idea of giving competencies. Is that you have to be specific as to what you are wanting to ask from the student. So please don't put the same topic as a question. Test the competency of the student. Test the competency, whether he has attained competency or not. So, for example, if there is one topic of philosophy of substantialism, that is one of the topics. So you can frame that what is his understanding of substantialism and what is its correlation with Hahnemann concept. This is acceptable. But don't give that word, elaborate upon the philosophy of substantialism. So then the entire purpose would be defeated of putting topic content and topic description. Similarly, if I have to ask him about the dynamic concept of health, I have to be specific as to what I am asking from. Similarly, if I am asking about logic, I have to be specific what I am asking from. It's the same for short questions also. So just don't write what is phenomenological medicine, because phenomenological medicine is one of the topics. So don't give, and that topic has to be covered in the short question. Right? I have a short question, so don't write short note on phenomenological medicine. This would not do. This defeats the purpose of topic content and topic description. Right? Yes, you can say, explain H.G. Roberts' concept of phenomenon highlighting the background basis of Organon. Or you can say, if there is one topic, relation of pathology to therapeutics. So you can ask, explain Emil Carroll's concept of general special therapeutics in light of his beyond with medicamentic lecturer. Or if there is one important topic is the biphasic action of medicine. So you can always ask in relation to biphasic action, what is Armstrong's law, what is the concept of pharmacy? Anyone you can ask. It's a 5-mark question because you just have to do 5 mark for that topic. So my point because assessment is the end point of your teaching, right? You all know. So if we are not assessing what we are teaching, then the teaching, neither the student would not be interested in knowing the details. You know? But if my assessment is pointed, focused, then the whole exercise would be meaningful. Right? This is the template that we have made to just give a content validity to the question paper. Right? Then coming to the practical part. So I hope no question. This format has to be adhered to. This is important. So it's not that I can give short note to any topic. We have specifically kept in mind the topics which have less competencies be given short note. The topics which are slightly elaborate be given long question, and topics which are skill based be given problem based. Because this format is across valid for all subjects, all PG subjects. 13 questions should be there in all PG subjects. 1 problem based, 4 long questions, 8 short questions. So this is there in all subjects. So every subject expert has tried to give small short question for a in which there is less competency, more competencies, a longer question, and where there is skill involved, clinical skill involved. We have kept it as a problem-based question. This is for all years. First year paper 1, paper 2, first year paper 1, paper 2, MD part 2, paper 1, paper 2. Right? Now again, just like theoretical paper has been structured, we have also tried to structure the practical part. So practical part would again have 2 components, summative and formative. Summative can be done through viva and clinical examination, and formative would be done through internal assessment. Now what are the methods you can use for summative? So for summative it will be a case based. You will be giving 1 short case and 1 long case. Again, the marks of short case and long case are slightly different. So this is the marks you have to give. Formative assessment is 20 marks, MD1 talking about. Then long case is 50 marks, short case is 20 marks, long book is 5, micro teaching is 5. Right?
Micro teaching during exam we have to conduct.
Micro teaching, again, there were 2 opinions about it. You can conduct during exam, no doubt about that. But since the student is already because the micro teaching cannot be assessed in 5 minutes or 10 minutes or 15 minutes. So that is why there would be some degree of biasness when we talk about micro teaching. Because see, a student who has been a good learner, right? He may not be able to present a good class towards the end of exam. May not. So micro teaching, that is why we have narrowed down the marks for micro teaching, so that you can give the marks of the basic exam, but you can also use your own internal assessment. Right? Because earlier micro teaching was 15 marks, but then we thought it will get a bias into because you cannot justify, student may not be able to justify his level of micro teaching in 5 minutes.
There is no journal in MD, sir.
No, that as a MD part 2 there is journal. When you do the internal assessment, part of the internal assessment, right? There will be logbook and case based. For formative, you can use if it is knowledge based, the MCQs assignment, you can find one. Skill based, you can do the mini CAs. OSCE requires a checklist at a rating scale, right? I will give you one example of how can we use OSCE or how can we use mini CAs for clinical exams. You can go to that. You know what is the difference between OSCE and mini CX? You and I was not knowing. When I started reading, I got it. See, mini CX is testing only one aspect of the entire thing. So, for example, I just have to check whether the student is good in case taking or not. So, my mini CX would be 0.1, 2, and 3. That's it. OSCE is objective structured clinical examination. OSCE is complete. Mini CX is mini clinical evaluation exercise. In case taking, for example, in case taking I just want to see how good his observation is. So then I will give him marks only for the 0.3. So that is my mini CX. Is my point clear? Mini CX is just one component which you are testing. OSCE is a complete structured clinical examination. Now what are the advantages? Advantages is right from the first step when he's greeting the patient to the last step when he's planning the management of the patient. You are giving him marks. And you're giving, so for example, if I don't want to give him marks, I can just have a checklist. I can just have checklist. But if I want to give him marks, then that becomes a rating scale. Right? So OSCE has both a checklist and a rating scale. Clear? Similarly, I can do the TOPS, direct observation of procedural skills. So for example, if I want to see whether my student is good at understanding pathology, so I can do a TOPS. Right? If I want to see my student is good in understanding miasm, only understanding miasm, then I can do a mini CX. If I want to see my child is good in clinical examination of the patient, then I can do OSCE. Clear? These are different modes. And each of these modes has a checklist or a rating scale. Checklist is I want to see the child did 6 steps out of 8. I can give him marks. Or I may have a rating for all the steps. Clear? So either I can, so that is why if you remember, so when we are doing the skill phase, so you can do a mini CX, you can OSCE, both will have either checklist or the rating scale. Okay? So this is the mark you can frame on your own. This is just a template. This is just a template for OSCE. Or this is a template for mini CX. Right? Okay? Then Homoeopathy 1 is internal assessment synopsis applied. Now when you talk of Homoeopathy, there are 20 marks each. So one is the internal assessment, then we give for synopsis, applied how much understanding of applied homeopathy the child has, the student has, what is the clinical understanding, and how well he can interpret the laboratory investigative findings. Because this is a part of clinical medicine in relation to philosophy. This is the marks that we have for each topic. Now list of references towards end which you find is all suggestive review. This is a very big list we have done. You feel you can add to this list, you feel you need not refer, you need not add. But we have also given topic list. Right? So to end it up, what is different in this curriculum from previous? Number one, it's a competency based. The idea is that the child should be skillful and should be able to reflect upon the topic. Second, it's a structured curriculum. Third, there is a horizontal integration of concepts. You will read the topics and you will understand that you have tried to integrate it horizontally. Then there is design, learning and assessment tools, and the emphasis on clinical application, problem solving and critical thinking. So this is all how to say this is the second argument. Dr. Alman, Dr. Karkeshwar Jain, Dr. Nehru, Dr. Abhishek, Dr. Munir Ahmed and Dr. Bipin Jethani, who gave us this pedagogical approach, because we had one day training to understand what is OSCE, what is, because they told us what, now we have to apply that to our subject. So they told us what is the template, we applied it to our subject. They told us what is competency, we applied to our subject. They told us what is EPA, we did the subject. They told us what is mapping of EPA, we did to our subject. So we had two trainings to start with Dr. Bipin Jethani and Dr. Munir Ahmed. Then thank you also for your team of Father Miller and my colleagues in the department, all of you. Thank you for giving your time.
Sir, you will tell about journal.
Internal assessment. When you talk of internal assessment, there are 6 components of internal assessment. One is the reflection part. The reflection part would include journal. In journal club or journal study, whatever you have, you can give it marks. But it's part of internal assessment. Similarly, internal assessment would also include, these are suggestions. Internal assessment would also include the basic professionalism in his case taking or in his pathology. That also can include in internal assessment.
Sir, any specific number was given, like how many journals
result is always there. We're not tinkering with that. But what is there in the gadget is mandatory. What is out here is to be followed in principle, not as a prescriptive.
So if the GCPDC get understood on the student to evaluate whether he has achieved the level of competency, and it's not actually going to understand it, you understand the issue of the level.
So that is
PD, that's what I was asking, whether we have to check
with formative assessment in first, you're dividing your PG into 6 semesters. 3 semester first year, 3 semester second part 2. So first semester you have to win this.
So it is that the CPA, whether we have to forget that in the EPA.
Yeah, no. Not necessarily you can correlate with EP. Not necessarily. Because even the EP is the end product.
So problems are some quality control, the quality cost will just 5P, and then once they check that whether the PD Moses statements as per the technology, we know that we are doing all this exercise and
You're doing exercise because you're completing the competency. You're doing the thing, you're completing the competency. You may not be completing the APA, but you're completing the competency.
So it's a getting checklist. So we are asking that we need to checklist for showing that this particular PG student
So see, the topic description has been given year-wise, right? It is not given semester-wise. It is not given semester. So in first semester, you can say, for example, the first year has 14 topics, and you're taking up the first 4 topics in first semester, that's okay. You've completed all the competencies.
whether there is any checklist of because one of the topics, for example, history of medicine, whether the student has understood is there any checklist? That's what we are asking.
That checklist you can, because we have given you the assessment tool. In every end of every topic, we have written that if you want to assess him on the basis of MCQ, go ahead and do it. For every topic, we have given you the tools. Now you want to do it in a checklist form, you want to do it in a mini CH, you want to do it a MCQ, you want to do a group discussion, you want to do a flipped learning test, go ahead. We have just mentioned the tools. You can frame your own checklist for that. Because if we start making checklists for each topic, for each tool, for each topic, then there's no end to it.
We are free to do all this.
You're free to do.
The problem is that in the last time when the CBDC, when the standard is when they say that some colleges and it is not the law of God, it's not the right, whether you like to do. You have to follow government.
Hey, what is the question? What is
The standard inspection came in, some inspectors, they take a different college. When they inspect our college, we have separate law book and the university. And this is the same, it is not the law book, it's not the law book, it is something else. And we did this law book.
See, I tell you what, one lectina that UG CPC left was, there was no standardized and was that there was no standardization of the logbook for each topic. They have said they have to have a logbook. They have written it as a, but there was no standardization. So what we have, for example, in our college, you check the NCM guide, National Commission for Medicine guidelines. There is one, and you pick up anatomy. It's the most basic logbook you can have.
So we cannot even follow the same calendar, but
That's because that you have, because there is no guide and I have to do it. So every subject has done that.
Kerala, what we have done that is the university has made a meeting of all the college in Kerala and we formulated
I completely agree with you, because none of the colleges had a structured logbook.
the person from other state, they actually came for inspection, they said this is not law, this is something else, we did this type of.
Because there's nothing structured at all.
That's what we are asking.
But out there in this you will find the structure for synopsis, presentation.
That's very good, sir. That's
See, actually, I to be frankly speaking, this is a new experiment for all of us. but this would surely come out because there's just so much huge information to cover. Now this is my choice. I cannot restrict him to two philosophers and say that you have to ask him only this, because as a student I need to give all the material. So yes, this problem would be there, that if, for example, I know hypocrites only, so I may just ask hypocrite, the teacher would taught to the which student may not have taught, for example, not taught hypocrites. So that would be
Is
there.
there any philosophy textbook which covers this topic in as well? Because it's a all the philosophy we have to go and philosophy. Actually, these are the topic for academic philosophy. But
I think, let me clarify. You just have to give him an overview of these philosophies in relation to homeopathy, on relation to animal thought. But we are nowhere interested in, for example, Leibniz philosophy. It's a huge empirical work he's done. Now I cannot ask him to read Leibniz, but I can surely ask him, from my understanding, what are the parts of Leibniz which are important to him.
so that's what I'm asking. Is there any such textbook which covers?
We've written all the mentioned. One good textbook is if I have not mentioned Will Durant. Will Durant, the influence of philosophy in medicine. Will Durant. It's one of the best books that you will find on philosophy. Or the Eckernet history of medicine gives a very beautiful exposition of philosophy. Eckernet I've had. Will Durant you can have. See again, this is not exhaustive. This is a work, for example, I am looking at from my perspective. I would have read one book. I could have not read 100 books of philosophy. So, for example, logic. Now, Erwin Koch, there is a book by Erwin Koch on logic. But I read it because when I started my MD in NIS, Homoeopathy, I found that book. But I intentionally have not written that book. Earlier I find it on net. Because that was my understanding of it. Now, that may not appeal to anyone or any teacher who is teaching. So there are a lot of books which may appeal to me, may not appeal to you. So we have tried to give only those books which are commonly available for the topic.
And one more question. So the last syllabus, we have psychology, but now psychology is already removed from syllabus. Is there equally?
No, not totally removed, but yes, it should be easily removed. But you can always take up, for example, whatever. See, we have certain, when we are talking about modern philosophies, I have added the Jungian psychology with homeopathy. Right? But you can surely take up Freudian psychology, or you can surely take up Adler in that concept. No problem. See, that thing, there would be certain topics which perhaps we would have missed out on. But we have kept certain topics to be open-ended. You can always add in that. So, for example, if you are talking about the modern correlation of modern sciences with homeopathy, you can surely add the part of psychology which you think is relevant to the student in that.
So the learning cycle is only about the area where homoeopathy
You can surely add. I agree that we could not give it justification in terms of the content because we have to cover so many things in that particular syllabus. So we can always, in those topics, we can always add. Jungian is my favorite psychologist, therefore I have just added that. So that I'm saying, these are just the guidelines. You want to put psychology, for example, you are teaching adolescence. You put that. If you're doing economics, you put that. If you want the Freudian school, you put the Freudian school. Ideas what? Ideas to tell student that this part of psychology is relevant in your history. Any other questions?
Regarding passing marks, as morning session is mentioned, 50%. I suppose if the students got the marks in practical module and in Viva, he got the 30, that means they should not be combined passing.
I'm not going to explain it. It is there in the template also.
They were mentioning 50%.
What is there? It is there. How much marks everyone has to get is there in the template.
160 plus 40.
160 plus 40.
160 plus 40. So that is 80 practical.
Right.
Even in 80, they will get 40 practical, 40 by
Yeah, it is written there. 40 that is, if I'm not mistaken.
So initially what we used to do, combine
I think any further doubts or any further questions? See, this is kind of a training for all of us. Ask you. Asking you can use for a short case. Asking you, for example, I'm looking for a long case. This is 50 marks because this is applicable for a long case. You can make a short case and use many schemes. So it is not necessary that you have to use ASCII everywhere. Let's say it's a short case and if you just want to see whether the child has been able to evaluate prognosis or not, or he is able to evaluate pathology or not, you just give many CX. That's a short case. Absolutely, these are different tools. ASCII, because ASCII is a structured program, so this one is more applicable for long case. Any further questions? Your colleagues anytime we can discuss. 98101. Very logical because this was kind of our attempt. We just made an attempt. You just look at and if you think anything you may improve upon, we can surely give suggestion to the commission. Right? So it is just an attempt on our part. It is just an attempt. So I am not saying when we will also start doing it, maybe we will also find difficulties. But as much structure as we could give to the whole curriculum, we have tried to give. Include trying to bring all topics together. Thank you friends, thank you. This syllabus has been more structured and more clinical based. But that's the objective. Assessment is also more structured.